Good evening, everyone. You are watching Dr. KK's Med Talks non-stop live. Welcome to the Med Talks Live, which is a conversation that matters and educational initiative supported by grant from Ally Lilly. I am Dr. Amit Gupta. I am your host for today's session. So, as we know, obesity and hypothyroidism are two of the most commonly encountered metabolic conditions in clinical practice, and their coexistence often leads to confusion. And there are so many confusions, and this leads to delayed intervention and sometimes unrealistic treatments as well, and many unrealistic expectations also. So many of the individuals they attribute weight gain solely to thyroid dysfunction, and this is a very common clinical practice that the people they come to us and they say their weight has increased only because of the thyroid, and the first thing they test is the thyroid function. While many others they assume that correcting thyroid levels will automatically resolve their weight issues or the obesity issue. So in reality, the relationship between the two is complex and multifactorial, and frequently it is often misunderstood. Against this backdrop, this very special episode, it aims to provide clarity through evidence-based discussion by separating myths from the facts. And this Med Talk session seeks to empower patients and healthcare providers with practical insights and science-driven guidance for better metabolic outcomes. So I welcome again everyone for this very, very important session where we are going to have Dr. Sanjay Kalra as the guest speaker. And so let us, I will request our team to play the obesity video. And so here I am going to present the key updates on the obesity. So are you going to present the video now, or do we have another that was just the video? No. Okay. So specialist reports link hypothyroidism and obesity with recurrent pregnancy loss. So this is I'm just enumerating the updates, and we will discuss these updates with Dr. Sanjay Kalra. And a preliminary study highlighted that children with obesity and subclinical hypothyroidism they can show early signs of kidney damage. So these are the updates, and this is very, very important because now the children are becoming obese, and the obesity in children is rising. At the same time, subclinical hypothyroidism also remains a major challenge. And now the studies they show that this can lead to early kidney damage. So it warrants early intervention, management of the obesity, and addressing the hypothyroidism as well. New clinical research, it also shows that the people in with type 2 diabetes, those with coexisting hypothyroidism, they tend to have higher BMIs, higher body mass index, and metabolic risk as well. So this underscores the needs to assess both conditions in complex cardiometabolic care. So it is very, very important to assess the people with diabetes for hypothyroidism and people with hypothyroidism for diabetes. And we will talk about this and understand more about this from Dr. Sanjay Kalra. Thyroid dysfunction during pregnancies again has been linked to increased autism risk in offspring. So this is again a new research highlight. And the higher BMI is also linked with increased risk of hypothyroidism in the population studies. So you can say the relationship is bidirectional: obesity linked to hypothyroidism, hypothyroidism linked to obesity, and sometimes there are many myths because they need to be addressed as well, because sometimes this bidirectional link may not be visible clinically and practically. So we have to address this in a very scientific method. So with this, let us go to the topic of the today. And today's topic is obesity with hypothyroidism. And we are going to discuss many myths. And I will be talking about myths, and our guest speaker will be talking about the facts. So now let me introduce our guest for today. And I know Dr. Sanjay Kalra. So Dr. Sanjay Kalra is a renowned endocrinologist of the country. He is a internationally renowned figure. He is currently the treasurer of the International Endocrine Society. He has written, I don't want to put a number, but numbers of textbooks, chapters, books, journal articles, and he is a very key figure in the field of endocrinology. Welcome, Dr. Sanjay Kalra, to the Dr. KK's Med Talk. It is a pleasure to have you with us. So
Thank you, Dr.
let me
Amit. It's an
briefly,
honor to be here.
yes, thank you, sir. So let me just briefly give you an oversight. So we are privileged to welcome Dr. Sanjay Kalra. He is our esteemed guest speaker. Dr. Kalra currently serves as treasurer, as I mentioned, treasurer of the ISC, and he is also the vice president of the South Asian Obesity Forum, a very renowned forum in the Southeast Asia, and is associated with Bharti Hospital in Karnal. He has decades of clinical experience. He is a kind of mentor to me, significant academic contribution all over the world, not only in diabetes but obesity and metabolic health. He is widely recognized for his thought leadership in patient-centered endocrine care. And when you look at his profile, he doesn't mention himself as an endocrinologist. He uh, he he describes himself as a lifestyle coach. And I think this is a very practical approach and a very decent way of describing himself. So Dr. Kalera has authored numerous scientific publications, state consensus statements, guidelines. So welcome, Dr. Kalera, again. And maybe you can have an opening statement, then I can go to the myths and the facts.
Thank you, Dr. Amit. Like you said, it's important to learn each and every aspect of medicine. There was a time when we were students, it was said that he who knows syphilis knows medicine because syphilis would impact each and every organ system of the body. Today, I think she who knows diabetes knows medicine. So it's good to know about diabetes. And also, diabetes is not a disease just of the beta cell. It impacts, like you said, there's a bidirectional link. It impacts each and every organ, each and every gland of the body. It is equally important to understand thyroid. I am reminded of psychiatry books of around 20 to 30 years ago. It was said that if a patient presents with symptoms related to three or more than three organ systems, hmm, so somebody coming in with easy fatigability, with dryness of skin, and maybe with menstrual disturbance, so three different organ systems, then you think psychiatry, think mental health. But that's not true. If a patient were to come with all these three things, we would think of diabetes and hypothyroid first. So that is how much we have grown and we have evolved in the past few decades. So that's the way forward. We need to keep on learning more and more about these diseases that are endemic to mankind and womankind now.
You are absolutely spot on, sir, because right now the way the metabolic health issues are rising in the society, and it is very easy to find three, four common disorders clustering together like diabetes, hypertension, dyslipidemia, hypothyroidism, cardiometabolic complications. So probably the dictum which you mentioned was if you have three or more conditions, symptoms, probably think of psychiatric conditions, doesn't hold true in the current scenario. And so let me start the discussion by asking one of the most common question which is asked about the hypothyroidism. And I think you must be seeing a lot of patients or persons every day. They come to you with a thyroid report and say, even without asking that hypothyroidism, I am gaining weight. Please check my thyroid status. Or is the hypothyroidism always the cause of significant weight gain, sir?
Not always. And we welcome all our listeners. Brisa ji is with us. Ali Nazakat Saab ko good evening. And Aditya Pannu, who is a young, handsome gentleman from Haryana. Good evening, Aditya. Akshay Adi is also with us. And Ramji Agarwal Saab ko namaskar. So, sir, your point is valid. Most people with hypothyroid do have obesity. Most people. That doesn't mean that thin, lean people can't have hypothyroid. Most people with hypothyroid do have obesity, but the converse is not true. Most people with obesity cannot blame their weight gain on hypothyroid. Even if you have both together and you were to control your thyroid very well, at the most you would lose 2 to 3 kg of weight at the most. And that is also going to be mostly body water or fluid. It's not going to be fat tissue. So whether you have a high TSH or a low TSH or normal one, if you are obese living with obesity, we have to find different reasons for the obesity.
So I think, sir, you have rightly explained that if even if you have hypothyroidism, the weight gain which is likely to be because of hypothyroidism, maybe 2-3 kg you can attribute,
Yes.
and this is again because of the fluid retention and the other aspects, and it is not the adipose tissue which is contributing to that most of the time. So the second
Right.
myth is also related to this because this is so common. And again, welcome to all the viewers who are listening to us. Please keep posting your questions also in the chat box. If you have any questions, we would be happy to answer those as well. So thyroid imbalance commonly leads to severe obesity. So this is a very big myth. And the first most commonly done test is the TSH1, which is done routinely. right and left without even thinking. So most of the time, patient will come with this report, and the next question they will say that my thyroid is normal and my weight is I'm still obese. So how do you explain that? I think partly you explain it, but probably our people who are not the healthcare professionals, but the uh, are people living with different conditions. Probably they are listening to us. So.
So patients with hypothyroid, they have a slower metabolism. That doesn't mean that they are not working, unless of course the TSH is 800 or something, and it has been there from childhood. That would be a separate matter. But those diseases are very rare now. In general, you can imagine that a person who is hypothyroid is working in third gear or in second gear. So the car, you can drive it from Delhi to Lahore or Delhi to Kolkata if you want, but you will be driving in second or third gear. So the person may be obese, but not morbidly obese because of hypothyroid. If otherwise, that person would have been 90 kg heavy. Now, with hypothyroid, she is going to be 93 kg, not more than that. So that is it. The opposite is more common. Opposite means that person is obese, person is now 90 kg, 93 kg. Because of that, the TSH is slightly elevated. So the TSH would come as 5.5, 6.5, 7.5. And the treatment is actually weight loss. You reduce the weight by 5%, and that TSH will come to normal. So basically, it's slowing of metabolism. If you are able to hasten the metabolism through exercise and diet, not through medicines here, if you're able to hasten it, the TSH will come down. And that is, let us go back to the car analogy. You've been driving in third gear because you never knew, the teacher never taught you that you have to go to fourth gear and fifth gear. Of course, many of the younger people will laugh at us because these are old age analogies. Now we have gearless cars. But what I want to explain is that if you've never driven a car effectively, efficiently, you won't know what the pleasure of driving is. If you've never exercised, you've never been physically active, you don't know the benefits of physical activity. So that is actually the commonest situation that we see in the OPD.
Sanjay, Dr. Sanjay said this brings to me another important question, which is linked to this only. Many of the time, we see that this is a clinical condition called subclinical hypothyroidism, where we see thyroid levels are between above 5 but less than 10 most of the times. And classical teaching is that if they have symptoms, which we say lethargy, fatigue, edema, weight gain, something like that. So, do you think obesity rules out the subclinical part if you see an TSH level of 7 or 8, or somebody is having is overweight or obese? Do you still call it subclinical hypothyroidism, or you call it clinical hypothyroidism?
Subclinical. So, though this is a misnomer in many ways, and a warm welcome and thanks to Syed Faraz Ahmed for being with us. And thank you. The honor is mine that I am able to work with Dr. Amit Gupta. He is somebody who has raised India's flag high at the global level in metabolic medicine. And we acknowledge the question from Akshay Adiji. We'll take it shortly. Dr. Gupta will address that shortly.
Yes, yes, yes.
So, if somebody has got a TSH between 5 and 10, and the T3 and T4 are normal, by definition, this is subclinical hypothyroidism, even though the patient may have symptoms. The reason is it's not that people are not aware. The reason is that these symptoms are more often than not, they are due to other issues. And to remember, you just remember the word lemon, Lemon. So someone with a TSH of 8 and obesity, or TSH of 8 and easy fatigability, may have these symptoms because of L for lifestyle, total lack of physical activity. So there's no physical conditioning. E for endocrine. It can be thyroid, but it also might be high prolactin or low testosterone. And this low testosterone will be fairly common in obese men. M is for metabolic. So other things like liver disease, kidney disease, and diabetes, the most common. So someone with a high TSH, 7, 8, and normal T3, T4 TSH, and symptoms may have the symptoms because of an abnormal lifestyle, unhealthy lifestyle. L, E for other endocrine issues. M for metabolic and medical things. The commonest would be diabetes. O for orthotic or orthopedic. Here again, what we want to talk about is exercise. The we call it Moan syndrome, MOAN. So hypothyroid people will come with moans and groans, but those moans and groans are because of M for muscular disease, like osteomalacia. O for osteoid disease, like osteoporosis, osteopenia. A for arthro disease, like osteoarthritis. N for neuropathy. So These would be common. That comes in O. And the last N, this is the most important. N is nutritional. So anemia, A, B complex deficiency, C calcium deficiency, D vitamin D deficiency, and E for electrolyte deficiency or dyslipidemia. This is the commonest. The patient may be complaining of moans and groans because of hyponatremia. So if we are able to rule out all this lemon, LEMON, only then would we be justified in saying that the patient actually has symptoms because of hypothyroidism. Then it would merit a short, a finite therapeutic trial. But even here, it would be more apt to do the finite trial for weight loss. So we tell the patient, you are overweight by 20 kg. Now, if the weight is 100 kg, obviously it needs more thyroid gland to survive. Your thyroid gland is only 25 grams. It is not able to work properly. As of now, you are compensated, but it's not able to work properly to handle 100 kg of weight. If we were to bring you down to 90 kg, then the thyroid gland would suffice and the TSH would come down. So this is how we counsel.
So I think that this brings a very important point that if you are able to bring down the weight, you are able to reduce the weight, then your thyroid function stands a chance to improve because actually you are offloading the thyroid gland by shedding the extra weight and you are reducing the burden of the our working thyroid gland. So this brings to an important question, and there is a question from Ruchika, and Mr. Ramji has also asked a question. I would like to ask you. Now we have obesity, we have hypothyroidism, and we start the treatment. So the question is directly related. So shall we assume that now the weight will automatically become normal because we have started to treat hypothyroidism, or so only treating hypothyroidism is alone sufficient for the management of the obesity or the excess weight loss?
It's not sufficient. At the most, you will lose around 3% of body weight. It will not reach 5%. So we'll have to add extra uh, therapeutic modalities, which can be dietary restriction, resistance exercise, and that brings us to Ruchika Sharmaji's question. Or it can be anti-obesity medications. But we will have to add something. With thyroxine alone, we will not lose more than 3% of weight.
And I think, sir, it again brings out the same point because hypothyroidism is not the alone cause for the
Correct.
weight gain, which is in excess of 20 kgs, 25 kgs. So you mentioned it is almost 2-3 kg. So you may end up losing 2-3 kg only because which is attributed to hypothyroidism. And to lose extra weight, probably you have to address the root cause of the obesity, which may be multifactorial in region, like lifestyle modification, lifestyle attributes, physical activity, dietary habits. So still you need to address all those things to have some important weight loss. So let us take. So I think this answers. Uh, so let me add this question to this stream only. So Ruchika is asking: is losing weight harder for people with hypothyroidism? So even if we
Yeah,
treat, yeah,
that is true, and that's because of multiple reasons. First of all, in general, in hypothyroidism, the muscles and bones will be weaker. So, because the muscles are weaker, uh, they are not very effective at exercising. But this is a temporary situation. Once you begin exercising, the muscles do respond. They become actuated, they become habituated. Another reason for making it harder for people with hypothyroid is they may have reduced gastric motility, GI motility, and that may reduce their tolerance of drugs such as semaglutide or tirzepatide. The answer here is that tirzepatide, semaglutide can be given to a person with hypothyroidism, provided that the TSH is well controlled. So, someone with a TSH of 12 or 15 should not be started on anti-obesity medication. Actually, it will be counterproductive. The tolerance will be very poor. The patient will end up with weakness with various symptoms. So, you tell the patient first, let's bring the TSH down to normal. Let us ensure nutritional optimization and endocrine metabolic optimization, which means optimizing the TSH, the HbA1c, for example, any other blood pressure, lipids. Let's optimize those, and then we start you on anti-obesity medication if required.
right. So I think, as you mentioned, the obesity sits at very high at the upstream in all the metabolic complications and probably drives not only just hypothyroidism but many other conditions. And it is important to address the obesity with proper approaches, which may not just include lifestyle modifications. But we have many other options available to us. Sometimes I think we need to look at those options also. So there is a very a question from Mr. Ramji. and he is talking about that Dr. Kalra ने अभी तक diabetes की बात नहीं की है. He is not talked about diabetes till now. So he is not having diabetes, but he complains that he is probably having some issues regarding the memory and all. So he says that can he attribute this to hypothyroidism? So am I correct, Ramji ji? Maybe you can type in the chat box, but Dr. Sanjay, you can answer this.
अग्रवाल साहब हमारे फेवरेट श्रोता भी हैं और हमारी इंस्पिरेशन भी हैं, प्रेरणा भी हैं, क्योंकि वो
Right.
मुश्किल मुश्किल सवाल पूछते होते हैं सर हमेशा। तो उन्होंने पूछा है कि दिमाग की डायबिटीज की चर्चा नहीं की हमने, और माफी चाहूंगा सर, हम मैं भी भूल जाता हूँ, भुलक्कड़ हो रहा हूँ। तो दिमाग की डायबिटीज एक्चुअली एक टर्म है, इसको टाइप 3C डायबिटीज बोलते हैं। उन्होंने ये रिसर्च की कि जो लोग हिंदी में सठिया जाते हैं या सतरा जाते हैं, ये पंजाबी फ्रेज होता है, इंग्लिश में डिमेंशिया जिनको होता है, या मेमोरी लॉस होती है, इनमें उन्होंने देखा कि खून में जो चेंजेस हैं हमारे नर्व सेल्स की बनावट में, मिलते जुलते चेंजेस पैंक्रियास में भी होते हैं, और उन्होंने देखा कि इन लोगों में डायबिटीज ज्यादा होती है। तो टर्म दी गई है डायबिटीज डिमेंशिया, या हिंदी में जैसे अग्रवाल साहब कह रहे हैं दिमाग की डायबिटीज। तो डायबिटीज और डिमेंशिया या भूल जाना, ये इकट्ठा चलता है। इसके कई रीजन हैं। एक तो जब शुगर हाई रहती है लगातार, तो वो भी पॉइजन का काम करती है ब्रेन पे। दूसरा, अगर शुगर लो हो जाए किसी की, सेम जैसे अगर आप दिमाग को खुराक नहीं देंगे, ऑक्सीजन नहीं देंगे, पानी नहीं देंगे, तो पौधा उगेगा कैसे, दिमाग कैसे उगेगा? अगर आप चीनी कम कर देंगे तो दिमाग नहीं उगेगा। और अगर ये लंबी देर के लिए लो शुगर चलती रहे तो परमानेंट डैमेज हो सकता है। इसके अलावा एक कॉन्सेप्ट है अवेयरनेस का, हंगर अवेयरनेस, थर्स्ट अवेयरनेस। जिनको डायबिटीज बहुत लंबी देर से हो, उनका ऑटोनॉमिक नर्वस सिस्टम, उनकी खून की नसें कमजोर हो जाती हैं, तो ये नहीं पता चलता दिमाग को या नसों को कि हमें भूख कब लगी है, हमें प्यास कब लगी है। इसलिए कई बार वो खाना खाना भूल जाएंगे या पानी पीना भूल जाएंगे, और पानी की कमी के साथ नमक की कमी हो सकती है। तो लो सोडियम, लो पोटेशियम, इसका भी इम्पैक्ट पड़ता है ब्रेन पे। ब्रेन को खुराक नहीं मिली दिमाग को, तो ब्रेन कमजोर हो जाएगा। और इश्यूज भी हैं, जिनको डायबिटीज होती है उनकी खून की नसों में काई जम जाती है। दैट काई या स्लाइम इन इंग्लिश, इट कैन बी glucose, it can be cholesterol, it can be tobacco. So people with diabetes will have higher levels of cholesterol. The cholesterol also gets stuck to the lining of the blood vessel. Because of that, less blood reaches the brain. तो फिर से दिमाग का बुखार हो जाएगा, क्योंकि खून ही नहीं पहुंचा दिमाग तक। खून कम पहुंचा तो उसने शुगर कम पहुंचाई, नमक कम पहुंचाया, एंड ऑल दीज फैक्टर्स लीड टू व्हाट वी कॉल दिमाग का बुखार। इसके अलावा डॉक्टर अमित, वी आर ऑल्सो गिल्टी समटाइम्स द drugs that we use, they also cause easy fatigability. Someone who is on
Right.
very high dose beta blockers, somebody who is on a drug which controls blood pressure while you are sitting down, but which reduces blood pressure when you stand. That also reduces blood supply. So many times our drugs also lead to this. And now, Dr. Amit, perhaps your opinion, we are seeing this use and misuse of modern anti-obesity medications as well. Sometimes they are used in the wrong people in the wrong dose, and that also leads to brain fog. People.
Exactly, sir.
So your comments on that, sir? Are you experiencing these things, and brain fog during COVID, after COVID, brain fog induced by ourselves, by our diet? Any comments, sir?
Sir, Sanjay sir, you have rightly pointed out because of the availability of these medications and the awareness which is happening around the obesity, a lot of people are using it without the advice of the experts. And we have incidences where people have taken the entire injection in one dose as well. And coming to us, doctor, I was not aware that I have taken the entire injection in one go. So how to handle this? And many people, they are coming with very side effects, just like brain fogging you have mentioned. That it may happen because ultimately because these are the drugs which are acting on the brain. So you have to assess the patients on a lot of things, not only just their physical health, but also the mental health, mental status, their acceptability to the drug, their ability to continue the drug for a longer period. And you need to look at the multiple conditions which you rule out before starting these medications. So I think the message for these drugs is very clear that they cannot be started in gym or the fitness centers. You have to approach a specialist, in case a endocrinologist or a physician, at least to know about these drugs and start these drugs. Otherwise, I think you are driving a you are on an uncharted plane and you don't know where you will end up and where it will go. So it can lead to a lot of complications as well. It is not a simple drug that you take as per for the cosmetic management. It is a serious drug, and we are addressing a serious issue of obesity. So this is my a few 2 cents for this on this account, sir. So I see there is a very interesting comment from the guy with the stranger, and he's saying the obesity is the uninvited guest at the thyroid's party. Completely agree with you, and the obesity doesn't come alone, my friend. It brings a lot of uninvited family members as well. And at the same time, when you say that how do we kick out the myths and get back to normal, so probably this is the show you should watch regularly and mention it to your colleagues and the friends and the family members that to know more and more about different topics, because this is the Matt talks about different topics almost on a daily basis, and you can pick up and choose your topic and learn more about it, and listen to the wisdom which is brought to you by many of the doctors. So I see another interesting question in the chat box, and it says that hypothyroidism, person lost 25 kgs, and still it did not bring down TSH in his case. However, when I gained back some weight, it did increase my TSH. So there was no impact when the weight loss happened, but on weight gain, definitely the requirement probably went up again, and the TSH had gone up again. Sir.
This is true, unfortunately, in many cases. And we also acknowledge the comments by Akshay Addy earlier. Akshay enjoys a height of 181 centimeters, weight is less than 69 kg, very well maintained, but still a good amount of midsection fat. So, this is part of being an Indian. We call it the South Asian phenotype. We have more of central obesity. So, that's the way we are built. Uh, you are losing weight in spite of good control. You might benefit from a test for celiac disease or wheat allergy. So talk to your doctor and see if you should be investigated for wheat allergy or gluten allergy, gluten intolerance. Also, diabetes is another cause. And sometimes when we go to get our glucose checked, unknowingly, while on the defensive, we eat healthy food. We eat less food and our glucose comes as normal. If you were to check your glucose repeatedly, you might find that you are in the pre-diabetic or diabetic stage. So check your glucose and HbA1c and ask your doctor if a celiac disease testing is indicated. Regarding your specific question about weight loss, now thyroid occurs because of damage to the thyroid gland. Damage to the thyroid gland will not occur overnight. It will keep on occurring slowly, except in people with congenital hypothyroidism, those who are born without a thyroid gland. Now, this gradual loss of thyroid function, it varies from person to person. In some persons, it may occur very fast. In other persons, slowly. That will contribute to the bulk of the rise in TSH. But apart from that, when you gain weight, there is something known as thyroid hormone resistance. So this thyroid gland secretes a thyroid hormone T3 and T4. These hormones act like keys, ये चाबी की तरह असर करते हैं, and they open thyroid receptors in the nuclei or in the center of various cells. When they open these receptors, the metabolism starts. When you gain weight, what happens is, just to explain in very simple words, ये जो चर्बी है, ये एक परत लगाती है सारी कोशिकाओं पे, कोशिकाओं के न्यूक्लियस पे. It creates a layer of fat or a deposit of fat around all the cells, especially their nuclei. And that causes thyroid hormone resistance. तो T3 T4 अगर थोड़ा बहुत हो भी body में, वो असर नहीं करेगा, ताले नहीं खोल पाएगा. Because it doesn't open those locks, that's called thyroid hormone resistance. Then the cells of the body, they send a message to the pituitary gland, to the brain, कि हमें भूख लग रही है, we are not getting our required dose of T3 T4. And the pituitary gland responds by increasing TSH secretion. So that is actually what happens. You will also find that TSH increases or decreases in logarithmic or geometrical progression. So very fast. While T3, T4, they decrease or increase in arithmetic progression very slowly. So there will be a very slight change in T3, T4, a slight change in body weight, but TSH will respond in a geometric or in a logarithmic manner. So which means you will find a relatively higher response. So don't worry about that.
So I think that explains very much. Sir, so there are two quick questions, and I think you have covered most of them in the previous discussion. So can we bring some? Can you spotlight on this fatigue and weight gain? they are always signs of thyroid dysfunction?
Not always. Commonly, yes, but in general, we sort of tend to overblame the thyroid. This
Yeah.
question was asked about how do we debunk myths, and what I find in the OPD is if I'm, let us say, writing 10 prescriptions for thyroid or for diabetes or obesity, at the same time I'm discontinuing thyroid and diabetes and obesity medication 5 times. So many of us are overtreated as well. So, how you help a patient kick out the myths and get back to normal is by just talking, counseling, educating, and doing it repeatedly. The question that you asked specifically about fatigue and weight gain, there are other common causes. The commonest causes in India, like we said, would be nutritional. So, remember lemon, lifestyle, endocrine, metabolic, osteo, and nutritional. In our practice, the commonest would be anemia, vitamin D deficiency, heat exhaustion, sodium deficiency. This is what is the commonest cause of easy fatigability. Another cause would be heart failure. You are getting breathless. So, Dr. Amit, see how this works. And again, as a society, we should be aware. We are very fond of criticizing doctors and the medical community for medicalizing normal disease, normal issues. So someone might say everybody grows old. What is the need for geriatric medicine or old age medicine? But did you ask the person who is growing old whether they want to be healthy or unhealthy? Another person would say menopause will happen to every woman. Andropause will happen to every man. Why treat it? But did we ask the individual? Actually, what is happening in society is we are normalizing sickness. So, Dr. Amit, see how this works. Uh, I am a 50-year-old lady with easy fatigability with breathlessness. Earlier, I was able to climb 10 flights of stairs. I was able to walk 10 miles. Gradually, I find that I'm not able to do that. So now I'm restricted to one flight of stairs and maybe 1 mile. What will I do? Immediately, I won't show the doctor. I will speak with my friend, my sister, my sister in law, my best friend. Chances are she's of the same age as me. She's from the same ethnic background as I am, the same social background as I am. So if I have anemia, chances are she will also have anemia. So I go to her and I say, sister, I am suffering from easy fatigability and breathlessness. Now I cannot climb stairs. I cannot walk long distances. Her answer is, I also have the same. Why do you bother? In Hindi, English, that's how we
Right.
respond. If it was Punjabi, so I would say, I have a pain in one knee. And her answer would be, Arey, I have a pain in both my knees. Sit quietly at home. No need to show the doctor. It happens to everybody. As a society, we end up normalizing illness.
Right.
Yeah. So for fatigability and weight gain, actually the issues are usually nutritional or lifestyle related. They might be medical, they might be endocrine and thyroid, but we should look at the lifestyle and medical causes first before jumping to endocrine or hormone causes.
I think this brings a very, very important point that doctors are not for the diseases, and they are. I see a lot of my colleagues and friends, they are advocating so aggressively and nicely regarding the lifestyle modification, regarding the importance of healthy eating habits, uh, uh, creating safe food environments, creating eating more healthier food, improving access to the healthier food. But I think at the same time, as you mentioned, that you cannot simply say that we are over medicalizing the aging or something like that. It is also about the quality of life. So a lady who was able to climb 4 flights of stairs and suddenly is not able to climb 1 flight of stairs at all. It is the quality of life that gets compromised. And probably, if we don't look at the medical causes, many of the times you may simply management of the iron deficiency anemia and giving a simple iron pill can bring down can elevate the hemoglobin from 8 to 12, and the person can be completely regain their quality of life. And sometimes you can discover some hidden disorders like heart failure with reduced ejection fraction and something like that. So decongestive therapy can improve not only the quality of life but also prevent many other complications which may arise in due course of time. So I completely buy your point, sir. And so let me move to the next question, though you have mentioned it briefly regarding giving an example regarding the driving the car in the first gear or driving the car automatically. So there is a myth that if you have hypothyroidism, then it will completely shut down the metabolism. So is it a myth or is it a fact?
It's a myth. It may slow down the metabolism, but none of this is irreversible. In fact, whatever irreversible Uncorrectable damage can occur because of not treating thyroid disease. That occurs only in the first 3 years of life, the first 1,000 days of life. After that, even if you did not get treatment for a short period of time, your TSH went up till 100 or 500, but then you restart treatment, all the damage that has occurred can be reversed, whether it is to the brain or to the heart or to the muscles. It can be easily reversed. So you really don't need to worry about that. You just have to keep your thyroid under control, and you have to take the thyroid tablet, of course, as required. But along with that, a healthy lifestyle will be required.
So we can welcome Arpita ji, and she is asking the question which we have answered earlier. So Arpita ji, we have mentioned that hypothyroidism cannot be the only cause of weight gain. The weight gain by hypothyroidism, just to sum up, maybe 2-3 kg. Taking treatment for hypothyroidism may end up losing 2-3 kgs which you gained because of the hypothyroidism, but it may not lead to the weight loss which you are expecting, and which is because of other reasons also. So probably simultaneous assessment for the other reasons of the obesity is also required. Maybe you can go back and watch the previous discussion on the YouTube later when it is available. So, Dr. Sanjay Kalwa sir, I would like to. This is a very interesting question, and this is regarding the diet. And I know there are a lot of myths regarding the diet. So, first of all, before I ask this question specifically, do you think there is any diet which is thyroid diet, or there is anything like called thyroid diets?
No, we need to be healthy. Actually, one of the commonest causes of poor control in our OPD is extreme diets. Someone taking fenugreek water or coriander water. In Hindi, dhania ka pani या मेथी का पानी. For added emphasis, the so-called celebrity nutritionist says you must take it in a copper jug. तांबे के जग में लेंगे तो ही असर आएगा. And the patient, the well-meaning patient, starts taking dhania ka pani या मेथी का पानी 1 liter every morning in a copper jug. अभी तो we thank those pseudo influencers for not saying gold jugs, because gold and silver are so expensive now, right? So they start taking that. What happens? The thyroid tablet stops getting absorbed. So all these extreme diets, they prevent the thyroid tablet or medication from getting absorbed, and people come back with high TSH. In general, a
And
healthy diet, balanced diet is all that is required. Nothing extra, nothing extreme.
And sir, at the most about the nutrition, which I can think, there was a time when the iodine deficiency, hypothyroidism, or the goiter was very common. Now, the with the regular supplementation of the common salt with the iodine, I think it is no longer exist. Most of the hypothyroidism which we see is autoimmune in nature. So probably even we talk about the whether people can take cauliflower or cabbage or something like cabbage and something like that. So probably if you eat once in a while, so that is also fine. So probably it is not the contributing factor to your diet. You may add more to this, sir, because this is a very
Not
common
anymore.
question which people ask. Yeah.
At breakfast or within 60 minutes of taking the thyroxine tablet, do not take soybean milk, do not take iron or calcium tablet, do not take an antacid, because that will prevent absorption. But the rest of the day, you can take anything that you want, and anything is fine as long as it is taken within limits. So these are, like Dr. Gupta rightly said earlier, which would mean more than a generation ago, the commonest cause of hypothyroidism, North India at least, was iodine deficiency. So our attitude, our behavior choices were based on that. Now the commonest cause across the country is autoimmune thyroiditis. So which means you have to treat it with thyroxine.
And sir, one
Balance would
because
be a
you
major one. Yeah.
because you just mentioned that how to take the thyroid medication and how much interval should be there. So this is a very practical problem. Sometimes our patients, they come to us and they say that they don't have that much time because they just get up at that time. They have to rush to the office, take the breakfast. So what alternative strategy they can have regarding the consumption of the thyroid tablet? Can they take it at the bedtime in the morning, at the night, or something like that? So can you throw some light on
Yes.
this?
So you can easily do that, whatever suits you. So best would be getting up in the morning and taking it immediately after getting out of bed. Also, it is said that you take the tablet before you freshen up, because you are sure that your hands are dry. There will be no moisture that will enter the thyroid tablet bottle. If you're not able to do that, you can take the tablet last thing before going to bed, just before switching off the light. But make sure that if there is a 2 to 4 hour gap between your dinner and the thyroid tablet. In case
So
you
if
forget
you
that, you can take it 4 hours or 3 hours after breakfast and 3 hours before bed. before the next meal. So take it in the middle of your meals.
So I think this is a very important point. So as Dr. Kalra has mentioned, take it first thing in the morning, and if you miss that, then probably you have to keep a gap 3 hours before and 4 hours after the tablet you take. So there is has to be a meal gap, and if you are taking your dinner early, maybe before 7 p.m. or something like that, then probably at 11 a.m. 11 p.m. bedtime you can take, because sometimes there can be because compliance can be improved by using these things. So I think this is very nicely explained by Dr. Kalra. So, sir, let me ask one more question to you. That what is the you have? I think you have championed this subject called stress, and you have published so many papers on stress and their effect on the metabolic health issues. So, what is the effect of the stress? Can stress cause worsening of the thyroid imbalance and the weight gain?
There are so many things that we are still not aware of. So many patients will come and say, uh, because of stress, because of intercurrent illness, my thyroid reports went haywire. This can actually happen. The reason is we have an explanation for that as well. The stress that is mediated in our body or in our brain is mediated by hormones. Thyroid is also a hormone feedback based phenomenon. So these thyroid hormones and the stress hormones, they talk to each other in the brain, and they might interfere with each other. So if you have any kind of physical stress or any kind of mental stress, especially physical stress, what will happen is that T3 and T4 may come down first, and after that, TSH may also come down instead of going up. The thyroid gland is not able to mount an adequate response. So these things actually do happen. In case you get a very abnormal report which you are not very comfortable with, you are not sure of that, just see if you had any intercurrent illness, see if you had changed your dietary plans, your sleep pattern, correct them, and you can check again after 2 to 4 weeks, and you might be pleasantly surprised the report will come back to normal.
So there are two, three questions, Dr. Sanjay sir, and they are again by Akshay there. So I think he is talking about a specific case. So first two I can answer, and I can say that, see, if you go for the fasting, if you have cardio training, if you are having muscle training, your quality of life will improve. But as Dr. Sanjay Kala has mentioned, that most of the time the thyroid disorder is happening because of the autoimmune in nature. There is a thyroiditis, there is some inflammation going on. So all these lifestyle modifications or methods may not completely eliminate the factor of the inflammation which is there. So you still need to take the medication regularly. It may not automatically correct every thyroid dysfunction. So medication will still be required. And this is a very important question, because can someone take one tablet a day, one sometime in the morning, sometime in the afternoon, sometime in the night? So what do you suggest, sir?
Yeah, that is fine. We need to have the total weekly dose in place. The reason why we can do that is because T4 has a very long half-life, 7 days. So once you have achieved steady state, which you will achieve in around 4 to 6 weeks, after that, you can actually plan this way. Theoretically, it is allowed. I will say theoretically. Practically, some people do it. You can take the entire week's dose at one go. So you might want to take 7 tablets every Sunday. Theoretically, that is allowed, but we don't practice that. So whatever Akshay is saying
So
is
I
fine.
think
No negative effect.
yes. So Akshay, you can do that, but under consultation. But most of the time, you can do that. But what happens is that sometimes you then, because you are having different timings, you tend to miss the doses because you are not having a discipline in taking the medicine. Then probably you're likely to miss some of them. So it is, you can do if your lifestyle doesn't allow you to stick to a time, but otherwise that is fine, as mentioned by Dr. Sanjay Kala, sir. So, sir, let me ask you another question, and this is also related to some exercise as well. So, there is a common myth that people with hypothyroidism, they should not exercise. So, is it really so?
No, they need to exercise more actually. And in thyroid, the muscles become weak. So apart from aerobics, we must have weight training or resistance training as well. So more exercise is required.
So, I think this is very, very clear that exercise, there is no contraindication for doing exercise. and you should do your exercise. But sometimes you may be having some additional complications in addition to hypothyroidism. For example, hypothyroidism is sometimes associated with heart failure and some other conditions. So probably a proper clinical evaluation and a doctor can guide you what type of exercise you can do. But it is very, very important to exercise, and exercise is for each and every age. And you can choose exercise as per your functional ability and the physical capacity. So, sir, now this is a very important question that once we have addressed how frequently people believe that once the thyroid hypothyroidism is being diagnosed, now the testing is will be very, very frequent. They need to test TSH levels very frequently, or sometimes people they do test TSH and as well as FT3, FT4. Some people do only TSH and FT4. So, what should be tested and how frequently it should be tested?
So in general, though we can't predict for everybody, in general, a stable patient should get a TSH done every 3 months, and a simple TSH will suffice. However, if the patient has central hypothyroidism, which means the thyroid is because of a pituitary disease, then an it the T3 and T4 that tells us actually what to follow. That is how we monitor therapy. So you might want to get a T4 done separately, but in general, across most labs, getting a T3, T4 TSH is economical, so that should be fine. So let me repeat again: somebody with primary hypothyroidism, Hashimoto's uh, thyroiditis, even congenital hypothyroidism, it is TSH that is required. For those with pituitary disease, central hypothyroidism, an FT3, a T3, T4. So that's general in 3 months. If, however, it's a special situation, patient is planned for an elective surgery, patient has pregnancy, patient is unwell, patient has symptoms which are not concordant with other lab reports, you might want to do TSH every 21 to 28 days as well. So in pregnancy, if we are worried, we can check the TSH every 28 days. Regarding FT3, FT4, this is a bit complicated topic. Now, actually, free hormones are tested by equilibrium dialysis. For equilibrium, you have to have equilibrium in the lab for 24 hours. Our colleagues in the US tell us that their laboratory accreditation is done on the turnaround time. So the turnaround time has to be 24 hours or less for all these reports. However, when you do the FT3, FT4, or when you free testosterone, you have to keep the sample in the lab for 24 hours. So if they do that, then they lose their accreditation or they lose their rating. So therefore, these short-term methods are done for FT3, FT4. So find out from your lab actually what kind of testing they are doing. Most of the
Right.
commercial labs do not
Uh,
do it properly. So you just stick to T3, T4.
and sir, a very quick comment. What is the right time to do the TSH? Can it be done any time of the day?
So yes, there are different opinions around that. In Usually, it is clinically not significant. You can do it at any time of the day. But if you want very tight control, for example, in pregnancy, or in someone where the symptoms and the lab report are discordant, then 8 a.m. fasting is what we ask for, early morning fasting. In my OPD, my practice is that if someone comes before 12 noon, we take the sample. If someone is coming after 12 noon, then we request them to come the next day for a test.
Right, sir. Sir, let me bring back the focus not just on hypothyroidism, again back to the obesity and the hypothyroidism and the obesity and the you can have both are driving each other to some extent. So there is another question, and I think you can answer this in isolation as well. Hypothyroidism, can we over the counter supplements which are available in now you have different supplements and there are chains of supplements which are supplying so many nutraceuticals you say. So what is the role of these nutraceuticals? Do they have any role in addressing hypothyroidism, in addressing obesity, in addressing a combination of hypothyroidism and obesity?
So there is discussion around micronutrients and thyroid function. Iodine is most important. If you are taking normal iodized salt, iodine deficiency should not be an issue for you. And there is no reason, not even any social or religious reason, why anyone in our country should say that I will take only rock salt. It just doesn't make sense. Ask the generation of doctors who worked so hard to bring iodized salt to national policy. Ask Professor Kochupille, who was my teacher at AIMS Delhi, how much of endemic goiter or iodine deficiency goiter he has encountered in the foothills of Uttar Pradesh in in Himachal Pradesh, erstwhile Punjab. Ask them, and then you will realize how much of illness, how much of disease we have been able to prevent. Just think for a moment. All of us say आजकल के बच्चे बहुत इंटेलिजेंट हैं, बड़े चुस्त हैं. Children of these days are so intelligent, so fast. There are many reasons for this. You know, the ecosystem has changed, education has become easier, more accessible. But think for a moment. The previous generation was iodine deficient, so our brains were slower. Today's generation has got adequate iodine, so their brains are faster, their nerves are faster. Because we don't realize these things, we stick to rock salt with a misguided perception that this rock salt is perfect. And when somebody sells us rock salt at 5 times the premium and also says that this Himalayan salt will expire in the next 1 year, the Himalayas have not expired for the last billion years, but Himalayan salt expires in 1 year. I fail to understand how this will further the cause of health. So, iodine should not be an issue if you're taking iodized salt. Regarding selenium, that's an important issue. Now, actually, our soils have become malnourished. I come from Haryana. Dr. Gupta also traces his lineage there. We are very proud of growing the best sugarcane and rice and wheat in the country. But when you check our soil, half of our soil is deficient in iron or in zinc or in selenium. That is why our agricultural scientists sometimes they are telling us to give potash, other times they are telling us to put urea because they know the soil deficiency patterns in different districts. Selenium deficiency is also common. If you take cereal that has been grown in a selenium deficient soil, you might be selenium deficient. But again, this is not a clinically measured problem. So that doesn't mean that all of us should take selenium supplements. There are two micronutrients that are endemically deficient in India, vitamin D and B12. These must be taken, but not for a thyroid purpose or obesity purpose. So that's the current status. If we are taking a balanced diet with micronutrient sufficiency, that that should suffice. If, however, we are at the extremes of age, we think we have absorption defects, or we are taking extreme diet, even vegan or vegetarian diet, or we are ill, we have concurrent illness which increases the requirement for micronutrients. Maybe repeated respiratory tract infection, maybe repeated gastrointestinal infection, then we should take a micronutrient supplement. But that will be to build immunity. That will be because our diet is inadequate. It will not be because we are obese or we have thyroid.
Right, sir. So, very well explained, sir. So, we should not take all the supplements blindly. And it is not that if we consume 4 or 5 tablets of the supplements every day, it will help us in building a good health. So, this is not the right thing to do. Take supplements, but take them wisely. Take under the supervision. Not every supplement is good for you. Sometimes there is an excess, and this toxicity can also lead to a lot of fatigue and a lot of other complications as well. So,
That's
yes.
yes. In fact, if you take iron or calcium within 4 hours of taking your thyroxine tablet, iron, calcium, magnesium, these will reduce the absorption of the thyroid tablet, and you might end up becoming worse.
Yes. So I think we should be careful about taking supplements, and we should take it as per the advice, or as per the need. If there is any need, then there is no problem, but don't overdo it simply because there is so many advertisements which are happening around it. So, Dr. Sanjay sir, we have few minutes left for today's show, and I would like to ask you that in 2026, we see that now there is a lot of awareness around obesity. We are doing this episode in the World Obesity Week, you can say, just 2 days before we had this World Obesity Day, and this is an obesity awareness month also. So, what is your message for the masses, and what is your message for the healthcare professionals who are going to treat obesity with the availability of new wave of anti-obesity medications in just couple of weeks of day from now? So, what is your advice, and what is your words of wisdom for them?
The anti-obesity medications are very useful. Obesity has actually become an epidemic in our country. In fact, it is endemic now to many states and union territories. So we should manage obesity. We have realized that lifestyle alone is not enough, it's not adequate. We should continue to follow a healthy lifestyle, diet, and exercise, but we need medication. So remember these M's. M is for mind styling. Keep your mind healthy, proactive. M is also for movement and meal planning. That's exercise and healthy diet. But then two more M's, medication and monitoring. Use the medication if prescribed by the appropriate healthcare professional. Do note that the Government of India mandates that tirzepatide can be prescribed only and only by a specialist in internal medicine or endocrinology. Semaglutide can be prescribed by a specialist in internal medicine, endocrinology, and cardiology. So reach out to the right physician. Monitoring is also important because many times if you overuse or misuse these drugs, you may end up with malnutrition. You may end up with other side effects. These side effects may be transient, but if the doctor is trained in picking them up, he or she will be able to minimize them and give you a healthy journey of weight loss. If the doctor is not trained, you might end up with injury or insult damage to the body. So that would be my take. Uh, Mind styling, movement and meal planning, medication and monitoring from the right medical care professional.
So I think that this is very, very important, and you have very well summed it up. Today, if you look at the global prevalence of obesity, it stands somewhere around 14 to 15%, 13%, and we know more than 47% of the world population is overweight. Right now we are not weight is not simply a cosmetic issue, or it is not a something. So if you think that you are obese or overweight, do reach out to your healthcare professionals for advice. Lifestyle modification is always the you can say the backbone or the cornerstone of the management of the obesity, because even I know many of my colleagues, so lifestyle modification is something which is there, but sometimes you're not able to do it because the obesity is not letting you do it, because you have so we are not talking about somebody who is having 10 kgs of the excess or 20. We have people who are having 40 kgs, 50 kgs of the excess of the weight, and probably asking them to walk or asking them to run or do some kind of physical activity and move around is practically not possible. So probably, and even these are the people who are sometime ideal candidate for the bariatric surgery also. But now we have the approach where at least the entire fraternity is now more geared up and in managing the obesity, because of and so much awareness is happening all over the world. Recently, our prime minister also talked about in a couple of his speeches that yes, obesity is a burden, and it actually adds to the lot of economic burden to the country as well, because of it leads to poor quality of life, hospitalizations, different medical complications. It is not just a fuel for the metabolic complication, it is also fueling the epidemic of the cancers as well. So there are many cancers which are directly or indirectly related to the obesity. So I think becoming awareness of having awareness of the obesity, try to cut down the excess food intake on yourself, try to improve physical activity. If still you are not able to achieve weight loss, then please do reach out for help to the healthcare providers, which rightly mentioned by Dr. Sanjay Kalra, who are authorized by the government of India to use a certain class of anti-obesity medications. So sir, last comment from you, and then we can wrap it up.
So it's been great being in conversation with you, Dr. Gupta, and with everyone else who has been with us. Akshay Adiji, uh, Arpita Ghosh Madam, the guy with the stranger. Please don't consider us as strangers. We are part of family. Tisha Best, thank you for your kind words. And Ramji Agarwal Sahab ko bhi thanks for his kind words and his support. Also, same for Ruchika Sharma ji, Sartaj Singh ji, and Faraz Ahmed ji, as well as Aline Zakir ji and Aditya Panno. Brizo, Visa, all these people, it's nice being with you. Together, I think we can work to ensure optimal thyroid function and optimal weight management for our countrymen and women. We just need to work together. We need to keep the conversation flowing. And thanks, Vinayak Sharma ji, for joining the conversation.
Thank you, Sanjay sir. It is always a pleasure, and I think it is. I love these opportunities where I can talk to you, I can have some conversation with you, and I learn myself a lot during these conversations. So thank you very much for your time and your precious words of wisdom today. So thank you, Dr. Sanjay Kalra, for joining us today. Thank you, Med Talks, and thank you. Dr. KK's Med Talks for organizing this very, very important topic today. So tomorrow, the Dr. KK's Med Talks will return at 7 p.m. with another edition of the show. and keep watching Dr. KK's Med Talks. And namaskar, pranam. Thank you very much to each and everyone. Thank you, sir.
Thank you. Jai Hind.
Jai Hind.